So yeah, people call me Dr. Serge. I trained at St. George's many years ago. So I was here for 6 years. I started in 2005 actually. Probably don't look it, but yeah, it's been sort of like 18 years in the making now to get to where I am. I'm about 3 months off of CCT. So yeah, we're going to go through emergency medicine. I'm an EM ST6 in the KSS Deanery at the moment, and we're going to go through how I did it, the training program a little bit, and some of the cases that I've seen, and yeah, hopefully keep it really interesting. And then we'll go into this at the end, and I'll tell you a bit about what I do as well on the side. So yeah, emergency medicine, new specialty, probably the newest specialty. But it is literally what it says. It's a field of practice. We have to acquire the knowledge and skills to literally deal with anything that comes onto our doorstep. We prevent, we diagnose. We have to, literally look into all urgent aspects of healthcare affecting any age group. So that in itself is very challenging, but it's very rewarding as well. And I'll go through later why exactly I love emergency medicine. Does anyone here want to be an emergency medic, by the way? Yeah? Got a couple of people? No? How do you think emergency medicine, what do you like about it?
It's quite diverse.
Diverse,
and
yeah.
You see patients at the first point of care.
Exactly, yeah. And literally, you're the one that they come running to with their problems. And literally, you've got to think about it, like you are that person who's going to give them some advice, and you could change their life in an instant, right? You could bring a bit of bad news, or you could tell them, oh, why don't you do this or do this? And they're going to go away and they're going to trust you. Many of our patients do, and they listen and they have to change their lives. So it can be very challenging. So yeah, you've probably all done some emergency medicine shifts, or, 24 hours in A&E is literally on our doorstep right here, which I've been on actually. But this is the chaos behind emergency medicine, and this is what I deal with literally every day that I'm working. So I've literally just done a whole week of resus, and yeah, it's like this. I've been seeing cardiac arrest calls. I've been dealing with problems that need to go to ITU, intensive care, stuff like that. So, you've got to be on top of your game in emergency medicine. Does anyone know who this guy is? Or hazard a guess of what he did? Anyone at home? Is anyone monitoring the home? Mm-hmm. Yeah. Any questions or? So this is a guy called Dominique Jean Larry. Okay, he was a French military surgeon from the French Revolution, and he actually did loads of work on the field, and he actually invented something called flying carriages. Does anyone know what that is? Basically, it was the old ambulances. So he invented the ambulances, and basically it was just horse and carriage, but the people with, the nurses or doctors, they would be on these carriages and they'd literally be flying around the areas, picking up, really sick people, legs blown off or chopped off or whatever, and basically invented pre-hospital medicine. So he is technically like the father of emergency medicine. That was back in the 18th century. Does anyone know who this guy is? This chap here. Has anyone been on any trauma courses? Or anyone want to be a surgeon? So this chap was an orthopedic surgeon. His name is James Steiner. Okay, 1976. He used to fly planes and stuff. he and his family were on a holiday and in Nebraska, and he crashed his small plane, and unfortunately his wife passed immediately. He had 3 children, and they all suffered quite severe head injuries. One broke their arm or something, and he took them to the local hospital, where the care was absolutely rubbish. And he basically came up with this. He said, and he did his own triage on the field, he did his own little things and stuff to try and help his family. And he said, when I can provide better care in the field with limited resources than what my children and I received at the primary care centre, there is something very wrong with the system and it needs to be changed. He was the father of, anyone guess? ATLS. So the trauma life support that we all have to do as emergency medics. And he basically, I think he's still going on as an instructor and he's still working really hard. He's been doing, lectures in Nottingham, etc. But, till this day, he's been the father of trauma life support, which is basically one of the main reasons why I love emergency medicine, that acute trauma stuff. So essentially, when it comes down to it, you're going to save a lot of lives. You're going to help a lot of people. It's going to be very rewarding. On the other hand, you are going to see a lot of sadness as well. And that is basically emergency medicine. It's very sort of up and down. But when you see those cases, those trauma cases that you help, it's amazing. It's an amazing feeling. Let's go through a case. Okay, we want some interaction here. So we have a 23-year-old. So we get an ASHITE. Basically, ASHITE is the red phone going off, the telephone. Paramedics call through. So we've got a 23-year-old. We're bringing him in. We're going to be there in 5 minutes. It's a rollover RTC, road traffic collision. Basically, give you a few things. He comes in, okay. So his airway is clear, okay. His C-spine is blocked. He's on a scoop. Have you seen a scoop before? So it's this basically clip-in mechanism. It's what the paramedics use to mobilize and transfer patients. So they'll clip it in that goes all the way underneath your patient, and then you'll be able to lift your patient and transfer them from the hospital, the ambulance, etc. So he's got shallow breathing. He's tachypneic. Okay, he's fast breathing. He's got reduced air entry on the right. He's got a very resonant chest on that side, and he's got probably a bit of tracheal deviation. Okay, that you think. You've been asked. You're the primary care doctor, right? You're doing the primary survey. And you're seeing all these findings. Circulation. His blood pressure is crashing. It's 80 systolic, and he's got a heart rate of 120. He's screaming and he's confused. His GCS is 14. And you don't see anything else obvious going on. Any thoughts? What are you thinking about? Okay, let's say you haven't got this patient yet. He hasn't come in and he's not on your table right now. But any thoughts? What's going through your mind? You're going to be receiving this patient.
Possible pneumothorax.
Pneumothorax? Okay. So you've gone straight to diagnosis. Okay. No, that's fine, because this is how we work. You have to be like that detective in emergency medicine, and trust me, you've only got sometimes literally like a couple of minutes. Some of these life-saving treatments that we have to do, you have to do them within 5 minutes. That's not a long time. Anything else? What else should we think about? What's going through your head right now?
His blood pressure's quite low. Like, is there some sort of bleeding internally?
Internal bleeding. So you're thinking blood. You're thinking, I need blood. Okay. Anything else? He's screaming.
He's conscious.
He's conscious. Yeah.
Does C-spine blocked mean that there's a suspicion of a C-spinal injury, or that they've just blocked it in precaution?
So basically, what we do in trauma is, if you've got potentially a life-threatening injury, like essentially a tension pneumothorax, and the patient's screaming, you don't know what's wrong with their neck, because we call that essentially a distracting injury. And he could have so many different issues going on, pelvic injury, whatever, but neck is very important because you need to prevent paralysis, right? So we block it. C-spine, even if it's a couple of pillows, if it's you in pre-hospital medicine, as a passerby, just hold the neck. But the neck is very important. But essentially, that's something that usually a hospital trauma call like this will always come blocked. Anything else going through your mind? He's screaming. He's like, analgesia, pain. So many emergency doctors, right? They think, I need to fix this tension, I need to do this, but they forget about these little things that mean so much for the patient. You've got to be careful though, because
of his respiratory depression.
Yeah, because of his blood pressure and his respiration, you don't want to put him into kind of like, hemodynamic instability. You don't want him to crash. So be very careful. But there's lots of good analgesic techniques out there. For example, Penthrox. Has anyone heard of Penthrox? Yeah, if they can use it, it's this inhaled sevoflurane device. It's very well used in the trauma field now, but that's a talk for another day. But yeah, so there's lots of different things to think about. In fact, as an emergency doctor, when you've only got 5 minutes to deal with something like this, so it was tension pneumothorax, I need to be putting in a chest drain, okay, so we'll move on. But these are the things I'm thinking about. I'm thinking about my team. Who have I got? Who do I need? I need nurses, I need people to run, I need porters, I need x-rays, I need imaging, etc., etc. I need so much stuff happening and I have to run it. You've got your patient, pain, you need to take an ample history, which is essentially a quick trauma history, allergies or their medications, any past medical histories, last meals or events leading up. As I said, distracting injuries, someone said blood, imaging, fast CT. Do you see how much you've got to think about as an emergency medic? Family, contact the family, let them know what's going on. Police, are there police that, was this a drink driving episode? Police are going to be badgering you. What do you do with the police? Do you have to call security if he becomes really agitated? What do you do if he becomes agitated and he's jumping off at you and he's trying to hit you? We've had patients like this where they're literally on top of you. I'm scaring you guys from emergency medicine now, right? And then obviously, where am I sending this patient? Obviously, someone with multiple injuries like this, you need to send them to somewhere like here, trauma center. Any questions so far? Okay, so that's me doing my ultrasound training. I'm just going to quickly run through, okay, for anyone who is thinking about emergency medicine training, what I went through and what I would advise you to do and think about from now. Yeah. Not the best slide, I'm sorry, it was off of the HEE website, which is not great, but essentially EM training, there's quite a few different ways of getting in, but the way I did it was standard run through. I actually took a gap year first, which is where this came in. So I started learning this doubler just before coming into med school, and when I finished, that's when I really pushed it in my gap year. 6 years of training. You start with your ACCS training, and then you go into your specialist training, which I'll go through. Okay, so what would I be doing now at your level? Okay, obviously you've got your work placements. Still do SSMs, selective study modules, where you can choose to go abroad. Yeah, so I went to India and I did 2 modules there. So I mainly did actually neurosurgery, and then I did pediatrics as well, and emergency as well, which I really loved. Because initially I wanted to be a pediatrician, but then I fell in love with pediatric emergency medicine, which is what most of my CV is based on now. Do you have clinical skills here? Tutoring? I would try and get into that, if you haven't already done so. become a anatomy and clinical skills tutor. Anyone doing a BSc? Yeah, what are you doing?
Oh, I'm integrating in primary.
Primary care?
Yeah,
Cool.
so general practice mainly.
Okay, fine. So I think there's probably like research, anatomy. I did anatomy and neuroscience when I was here. Loved it. But essentially, what you've got to do from now is try and build your interest. You guys are at a very young stage, and I'd say definitely enjoy your medical school. But think about, you know, the next sort of 4 or 5 years, your foundation training, where you want to be, what you want to do, okay? Essentially, everything is on the HE website, how to get in and stuff. But there's, you know, the competition ratios actually are going up. So it's like a 5-to-1 thing now. So you've really got to push your portfolio and build your portfolio. There is the clinical test and, you know, problem dilemma test, which is the MSRA. And then there's a virtual interview, which makes up most of the points of getting in. But you can really build your CV from now. Not everybody will get into training first off. So I actually took an F3 as well. I did a bit of traveling. I did a clinical fellowship here. So I did pediatric emergency medicine here. And essentially I started building my CV. So I did a lot of extracurricular stuff with this. I went on to courses. So I did ultrasound, I did trauma courses and stuff. The best fellowships are going to be here in Brighton. So you've got the best emergency medicine consultants, trauma consultants. Have you ever worked here in the emergency department? What did you think of it?
Very organised chaos is what I'd probably call it.
Organised chaos, yeah, that is how everyone describes it. But essentially it is that word, it's organised, and it's really well run. To be honest, this St. George's is it's exemplary for emergency medicine. It's amazing. And, you know, like, I would definitely, you know, think about a fellowship there. Obviously we all need to make money, so locum, so that you can pay for your courses, because they're very expensive. Once you get into training, then the best thing about emergency medicine is they will pay for most of your courses, which is really good. And the RCEM website, Royal College of Emergency Medicine website, is amazing. So I would advise, join that. You can get an e-portfolio through the RCEM website, and you can literally do assessments with your consultants and then just stick them straight onto there, and then literally build like that. ACCS, okay, it's 3 years. You've got emergency medicine, acute medicine in your first year. I think you were thinking of acute medicine, right? Possibly. Year 2 is anaesthetics and ITU. And then year 3 is your pediatrics and core emergency. But can you see like how well-rounded it's going to make you as a doctor? You're going to learn your airway management. You're going to learn, you know, how do I deal with blood pressures? I can put in central lines. I can do femoral lines. I'm going to go through some of the procedures, but you're going to pick up some of these amazing skills that, you know, a lot of trainees don't get. Okay, I will move on. These are some of the skills. There's a long list. It goes on and on actually, but these are the procedural skills that you're going to learn in ACCS. You're going to be able to, if I say to you, oh, you know, I'm your consultant, whatever, can you go and put chest drain in that person? Cool. Can you go and do a knee aspiration? Can you pace this guy? Can you cardiovert someone? You know, they come in fast AF, they're unstable, you need to shock them. Can you go do it? Or can you cardiovert a SVT? How would you do that? Anyone? Good IV access. Your ultrasound skills are going to be amazing. So you can use ultrasound for vascular access. You can get in line, give them, anyone know the drug to convert an SVT?
Adenosine?
Adenosine. Yes. I mean, obviously you do other things like vagal maneuvers and stuff, but yeah. So you know, you'll be becoming a very good all-round doctor. Now that I am in higher training, I do a lot of higher training kind of teaching to my colleagues and stuff, and also, trying to teach them how to actually do your portfolio. It's a little bit far for you guys, but essentially you can become specialist life instructor. You can, you know, start doing your own journal clubs, research, quality improvement. I've just done a whole kind of 3 years of quality improvement on ketamine. So when a child comes into hospital, let's say they've badly broken their wrist and they're screaming in pain and you need to straighten it, the child's not going to let you do that, right? You have to sedate them there and then. So I've just done a whole policy on ketamine sedation in pediatrics, which has been published. So you get to do some really cool stuff like that, and I'm just about to re-audit it actually, and so far it's gone really well. You get to go on really good training days, monthly training days, plus training days that the hospital runs. You can do trauma training, so TTL is trauma leadership, and then obviously your exams. So you've got your MRChem membership exams in ACCS, then you've got your fellowship exams, which I would advise to study really hard for, like you're doing now. Any questions so far? Cool. So these are some of the learning outcomes that we do. Now, obviously, these are the high training SLOs, but they're training you to become that ED consultant who can literally manage the whole of the emergency department. Every angle is under your care, and that's what we work towards. Okay, these are some of the higher procedural skills that we go through. Okay, so you said blood, yeah? When you've got a bleeding patient, do you know what we have to do in that situation? Like exactly. It's not actually that simple of a procedure. There's literally so many steps in order to get blood, or what we call flying squad blood, which is like O negative or O positive blood. Literally, if you've got a bleeding patient who's dying in front of you and you need blood straight away, it's so many steps, but it's part of the training that you learn how to actually manage that. There's so many drugs we use, and to be honest, now that I'm at this stage, I've pretty much done all of these in some way or form. So you do a lot through simulation, but I've actually done these on patients, people. I'm going to go through one case. What's this? Sorry, it's a bit gruesome, I know, but what is it? I don't know your name. You're looking really confused. Yeah, you. Earrings.
Me.
Yeah. What's your name? Javier. What do you think's going on here? What are we trying to do? What can you see? What's this?
The heart.
Yep. What's this?
Lungs.
Lungs. We are literally ripping open the chest because we have to, if it's, usually this patient's coming to you pretty much dead. Yeah, they're dead. Yeah, you haven't got long. You've got literally a few minutes, as I said, a few minutes. You've got to rip open that chest, either evacuate the blood or you have to repair the heart. That's what we do in trauma. That's what emergency medicine is, really. It's stuff like this. It's very rare, but I've actually been involved directly in one throughout, but I've seen 4, and most of them I've seen here at St. George's. And you've got a guy called Anthony Hudson, who is a legend. I don't know if you've met him, but he's a St. George's ED consultant. He's also the lead of HEMS, so helicopter emergency, for London. and he was the head. I'm not sure now, but he's literally a legend. He will literally just rip chests open and deal with stuff like this, and it's crazy. Not many trainees even get to see it, but you never know. One day you're the consultant, you're like the trainee on shift, and your consultant's like, we've got to do this now. We've got to open this person's chest. Can you imagine? So we can do subspecialties in emergency medicine as well. I've got colleagues and stuff who've done peds, we can do pre-hospital stuff, intensive care, and then there's a little, there's a path of getting into sports as well, which would be cool, working for football teams or whatever. What is my work day actually like? So it can be pretty crazy. As I said, emergency medicine it's not for the faint-hearted. It is, it's really good training. It'll make you into an amazing doctor, very organized. You have to be literally on your game, on your top game every time, because you haven't got long to see your patient, right? We do between 9 to 10 hour shifts. We start at any time of the day pretty much. We do a lot of night shifts, okay? Usually when I come in, I have to take handover from the doctor or the consultant, and I have to lead an area. So whether that be resus, which is what I normally do because they do that in higher training. So I get to lead all of the resus cases that come in, or allocate people. If you guys come to me actually as medical students, I'll literally give you a patient and be like, see the patient and then come and present. Obviously supervised, but you could be in charge of majors, peds, RAT. RAT is rapid assessment. So like when the ambulance comes in, you triage. You're seeing approximately 12 to 20 patients a day. Sometimes, the most I've seen in pediatrics is around 30 a day, and on night shifts, very busy night shifts, I see about 28 with a junior. So I've got the junior with me who's doing all of my admin, and I'm literally just seeing and blasting through the patients. It's so busy. About 80 to 90% of patients, obviously at the moment, don't even need to be in A&E. They could be managed by community health, GPs, whatever, but unfortunately the system is such that they have to come in because they need that. Honestly, that reassurance, which is what we give them. Communication has to be amazing. That's why St. George's is the best, because your communication skills are the best, right? Out of any other medical school. So yeah, 10% of my resus cases is proper trauma, where I'm doing stuff. We see a lot of silver trauma. Does anyone know what silver trauma means? Basically a fall in an elderly patient. Even from standing, they could have fatal internal injuries. So you have to be really careful, they suffer from osteoporosis, they're on blood thinners, they've got, half of them have got atrial fibrillation, they're on a Pixaban or something, so they could suffer from severe internal bleeding. So you have to be literally very careful, with these kind of patients. Okay. So as I said, it is literally like this as I come in. Corridor medicine, you're seeing patients literally one after the other, and you don't really have anybody there. Like the nurses are super busy. You've got to do a lot of the bloods yourself, cannulas and stuff. Everyone is amazing though. The team is amazing, which is why I love it as well. And honestly, the support you guys will get is amazing as well. So you've always got Regis to talk to. The consultants are literally there. ESAR is really good because the consultants, you've got one consultant who's just sitting at a computer and you'd be like, Serge, what's wrong with your patient? Tell me right now, you've got 10 minutes. What are you doing? Refer, do this, So it's pretty good for training as well. And you're continually assessed and you're always supported. Okay, one more case, last case, okay. 45-year-old. This is one that I saw at Royal Surrey Hospital a few years back. I was on a night shift. The consultant literally just went home. 45-year-old intoxicated, history of assault, came in alone with paramedics, GCS again 14, confused, agitated, in pain, with facial trauma, okay? And he keeps saying to the nurse, so you've got to remember in emergency medicine, like, a lot of patients come in and they go through triage, but not everyone is assessed immediately by a doctor. And the nurse obviously highlighted it, but the patient slipped through and kept on complaining about this for about an hour. I cannot see, I can't see. What's going on?
It's like
We've got an ophthalmologist in the room, by the way.
compression of the third nerve, possibly.
Compression of
The third cranial nerve.
third cranial nerve? What does the CT show? So we call this a retrobulbar hemorrhage, okay? Now there is compression of the optic nerve, and that's why he's literally going blind. And if you don't decompress that, within 5 minutes, he's gonna be blind for life. So what do you do? Let's go back to it. So literally, I was on shift, I had never seen this before, I'd never done this, but this is emergency medicine because you don't know what you're gonna see. And this guy comes in, what do you have to do? What do you think you have to do? You literally have to stick a needle in here, we call it the lateral canthus side, okay? And you put in a couple of mils of local anesthetic. You haven't got long to do this. Do you know the ligaments of the eye? Yes.
No.
So you've basically got your canthi, yeah, you've got your superior and inferior canthi. You have to cut them, yeah, you literally just have to cut them to release that pressure. And then obviously ophthalmologists can take over after that and drain or do whatever they need to do. This guy, yeah, I've never heard someone scream like that much. He was in severe pain. And the books, the textbooks. So what we had actually done is me and the other registrar who was working with me, we'd never done this before, but our consultant had. Now she had just reached home in Kent, so she was traveling from Kent. I called her and she literally said, I'm not coming in, I can't, I've just reached home, you need to do this now. So we had her on FaceTime, yeah, I'm not joking. So Dr. Clark, Royal Surrey she was. She's on the phone and we are doing the procedure, her guiding us over phone. How crazy is that? That is what we do. In fact, I've heard cases of the thoracotomy and stuff, coming in at night when a reg is on lead and their consultants from home guiding them to do thoracotomies. So yeah, life-saving treatments, but very rewarding. This guy, we saved his sight. So obviously we didn't know what we did, but we cut it and he screamed the hell out of the place, and but we saved his sight. So it was pretty cool. And it's a case that went into my portfolio straight away. And yeah, it's going to be there for life, right? So why do I love emergency medicine? So we are at the forefront, okay? That's me and the team at Royal Surrey. So I did most of my training in Royal Surrey. So I did obviously the St. George's Clinic Fellowship, then I basically started my ST3 at Frimley. And then I've done most of my training in Surrey, so I'm Surrey trainee. You get to see all of this amazing variety of cases, okay? You face amazing challenges every day, you know, like you're basically training people all the time. You've got medical students with you, you've got to teach them, plus look after your patients, plus do this. Your time, literally, you start, you clock in, you clock out, you don't even know where that time has gone. It's, you know, when I did ward medicine, I'd go to a ward and I'd, you know, do the ward run with the consultant, which would finish at like 3 o'clock in the afternoon. Then you do your jobs, and then you're literally leaving late every day because they finish so late, and it sucks. I hate it. The reason I chose emergency medicine because you are independent and you get to do what you want to do basically, and you can have discussions with your team leaders, your consultants, and you can basically have fun on the shift and learn. You learn so much, and every day is a new day, right? You literally don't know what's coming in, and you'll see some crazy stuff. You get to really hone down on your leadership and communication skills. You know, the other day I was breaking bad news multiple times because January is a horrible month, and we're seeing a lot of RSV, COVID, and had to put 4 patients onto end-of-life care this week, and I've got to do a death certificate actually when I go into shift tomorrow. So it kind of sucks sometimes, but your communication has to be on point, so you're breaking bad news a lot. As I said, very supportive work nature, okay? You've always got people around. The nurses are amazing, especially pediatric nurses. I've got to say, they know everything. So if you've got any problems, and I'm sure you guys will all rotate through emergency medicine. Mostly, I think nowadays they do that. And to be honest, our F2s, they love it. We've got F1s in Royal Surrey as well, and they love it because they learn. As I've been through all the practical skills pretty much, but you get to do so much stuff. Education is, you know, for me it's very important, and you get to do obviously the exams, but you also get to teach other people through trauma life support, advanced adult life support, and pediatric life support as well. There's lots of things. And there's also the time for extracurricular activities. So what I have done for the last sort of like, well, I started actually, I wouldn't call it a company just yet, but this is my side hustle. So basically Dr. Doubler. So this has been going on now. So I started this 18 years ago. I was actually called like London's Doubler guy or something. And I started here at St. George's. I formed a society called Doubler Dol Bhangra Society. I think it fizzled out because it was only here until I was here. And we used to teach students Doubler, we used to do Bhangra as well, and we used to play Dol. So you know, it's always been a family thing. My brother's into music and stuff. He's an optician actually, I was saying. My whole family are opticians, but we do a lot of music on the side. And essentially it has always been that thing that has released like all that tension that I get when I do medicine. I see these crazy difficult cases and I come home and I'm like, you know, I've got my family who I can talk to, but essentially I use this and our religion, Sikhism and stuff, and I also lots of different types of music to have that self-therapy kind of thing. It really de-stresses me, and it's something that I would advise you all to try, is learn something, or carry on with your hobby. If you've got a hobby right now, or you've learned a musical instrument, don't give it up, because it's really going to help you. You can pass it on, you know, to future generations. This is what I'm trying to do. So Dr. Doubler is family. It's me essentially playing this and teaching others how to play. Obviously I think you guys found me through Instagram and stuff, but I have YouTube, Instagram, TikTok. I'm trying to create a online school website, so please share and let people know as well. And if anyone wants to learn as well, happy to give lessons. But we do charity gigs. I've got charity performance coming up in April at Royal Surrey Hospital. Play with other consultants who've kept on. I've got, you know, we've got a whole band of guitarists. They all trained at St. George's as well, but they're all ED consultants or paediatricians as well, actually. I'm part of a blues band. We play around London as well. We do collabs with different people across the world. And yeah, we do events like this. And weddings and whatever, birthdays. So it's been pretty cool. And yeah, you're probably like, how does he get the time to do this and emergency meds, saving lives and stuff? But as I said, yeah, like, you ask my family and they're like, oh, he's at it again, he's in his room, he's playing and stuff. But I love it. 20 minutes a day is my therapy. And yeah, what I'd like to do before we all munch on some pizza is a Vuru Sim. Now, for those of you who don't know what Vuru Sim is, it's essentially it's a religious prayer. Okay, Vaheguru is a term that refers to God, and essentially it's a form of meditation. Okay, I do this with tabla. I've been doing this for many years. It's obviously very close to my heart, and essentially it gets you into this kind of meditation, and it's said to take one from darkness into light. So if you're having a bad day, and when you're doing your foundation training, it's not easy. You're literally going to be thrown into a deep swimming pool end or whatever, and it's not easy. And there's many days I've come home and I've nearly cried. I have so many of my colleagues, they cry. It's tough sometimes, what we do, but we keep strong, and it's stuff like this which keeps us strong. It's our faith, it's our family, and it's like literally, the love for the job as well. So I'm gonna do this for you. It's gonna be about 10 minutes. So if you want to close your eyes, that should work. All right. Okay, if you want to just close your eyes and just let's do this.
Vaheguru, 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 Vaheguru.
Everyone relaxed? Everyone hungry? Thank you everyone at home for joining. Yeah, I wish you all the best and take care. Have a good 2024.